All right, so my case study is entitled Dehydration with Severe Malnutrition Requiring Enteral Nutrition Support. I'm currently at Novant Health Rowan Medical Center in Salisbury, North Carolina. To start this case study, I want to talk a little bit about dehydration. We all know the importance of water, as it is the largest single component of the body and is integral to cellular function. In adult men, about 60% of their bodies are made up of water. Dehydration occurs when an individual loses more fluids than they are taking in, and the body does not have enough fluid to carry out normal functions. Frequent causes of dehydration include excessive vomiting, diarrhea, and sweating. The adequate intake reference value for adult males greater than 70 years of age is 3.7 liters of fluid per day. Signs and symptoms of dehydration include extreme thirst, less frequent urination, dark-colored urine, fatigue, dizziness, and confusion. Lab values affected by dehydration status include albumin, transferrin, sodium, BUN, creatinine, hemoglobin, and hematocrit. As this water droplet says, drink your water, it's very serious business, guys. Adequate hydration is especially important in children and older adults. To understand hydration, we must first look at the mechanisms of fluid balance. In healthy individuals, kidneys are highly sensitive to fluctuations in the diet and fluid intake by compensating the volume and consistency of urine. The hypothalamus, the renin-angiotensin-aldosterone system in the kidneys are responsible for maintaining extracellular fluid volume and osmolarity. Renal excretion and retention of sodium are under control of aldosterone. The hypothalamus stimulates the pituitary gland to release the antidiuretic hormone whenever blood pressure falls too low. The antidiuretic hormone stimulates kidneys to reabsorb water and recirculate it rather than excreting it. The body uses this process to maintain homeostasis for as long as possible. In this chart, you can also see what happens when we intake too much fluid. The second topic of this case study is malnutrition. Malnutrition is defined by Aspen as an acute, subacute, or chronic state of nutrition in which a combination of varying degrees of overnutrition or undernutrition, with or without inflammatory activity, have led to a change in body composition and diminished function. Here's a chart that we're all pretty familiar with. We can see it's the A&D and Aspen guidelines for clinical characteristics to document and support a diagnosis of malnutrition. The clinical characteristics include energy intake, weight loss, physical findings, i.e. body fat and muscle mass, fluid accumulation, and grip strength. Two or more of the clinical characteristics must be met to diagnose a patient as malnourished. In the clinical setting, nutrition-focused physical exams are extremely important to determine body fat and muscle mass loss. At Rowan Medical Center, a nutrition-focused physical exam must be completed to be reimbursed for a malnutrition diagnosis. So from this chart, you can see that there is moderate or severe malnutrition, and it can occur in the context of acute illness or injury, chronic illness, or social/environmental circumstances. To identify this malnutrition, all patients are subject to the malnutrition screening tool during the nursing admission assessment. The Joint Commission requires that this nutrition screen be completed within 24 hours of admission. Up in the upper corner of this slide, you can see the questions that are asked from the screening tool. Answers provided generate a score, and a score of 2 or more generates an RD consult for further assessment. Patients are also reevaluated every 5 days by the nursing staff using this malnutrition screening tool. In the lower corner, we can see the flow chart of the nutrition care process, and we're talking about the admission part of this process in which the patient is screened and determined at risk or not at risk. So nutrition support recommendations for malnutrition are very important, and they should only be considered when there is an inability to meet nutritional adequacy via oral intake. Of course, we know that even only when minimal GI function is present, every attempt should be made to provide needs via enteral nutrition. If the gut works, we use it. I repeat, if the gut works, we use it. Current nutritional guidelines recommend that EN be started within 24 to 48 hours in critically ill patients who are unable to maintain volitional intake. And below you can see the indications of enteral nutrition and the contraindications of enteral nutrition that we're pretty familiar with. Here is Professor Bryan's nutrition support protocol flowchart. It is relevant to this case study as the patient required the initiation of enteral nutrition. So I had to use this flowchart in deciding, well, nutrition support is needed, and what route are we going to go? In the end, of course, we chose enteral nutrition for this patient because his gut was fully functional. And that leads me into the next slide, which is the percutaneous endoscopic gastrostomy tube, also known as PEG. So For patients that need enteral nutrition for longer than 4 to 6 weeks, long-term access is obviously needed. Insertion of a PEG is one way to provide foods, liquids, and medications directly into the stomach. And here you can see a little figure of what a PEG tube looks like, and that's into the stomach there. And there's a bumper and the clamp and the adapter. So what's really cool about a PEG tube is immediately after placement, it can be used for medications, and then within 1 day, it can be used for tube feeding formulas. So you're talking about a relatively quick turnaround time for patients to receive adequate nutrition. One problem that occurs when tube feedings are begun is intolerance, and unfortunately, a lot of patients maybe don't get the nutritional needs they need because staff are unaware of how to handle these intolerances. And so this is a summative table, and my facility actually posts this table in the nourishment room of the ICU as a little reminder to staff. The main takeaway from this is that enteral nutrition should not automatically be withheld when gastric residual volumes are less than 500 milliliters or when diarrhea occurs. And this is a common misconception between dietitians and nursing staff at ROAN. Katrina actually works very hard to educate the staff on recent research findings regarding this topic. And so one of the supplemental papers that I've included in this case study is about maybe challenging clinicians to think differently about using gastric residual volumes in the delivery of patient care. Now, one thing that is, of course, of concern is refeeding syndrome. And refeeding syndrome is the metabolic process response to nutrient provision in a malnourished patient. It's simply the switch between a catabolic state to an anabolic state. And what happens in refeeding syndrome is insulin, in response to obtaining these carbohydrates that our body so desperately needs, drives glucose and vitamins and minerals into cells and resulting in an intracellular shift of electrolytes. What we then see is a drop in potassium, magnesium, and phosphorus. Sorry, brain fart there. So the possible clinical complications that can occur from refeeding syndrome are arrhythmias, cardiomyopathy, Wernicke's encephalopathy, anemia, coma, and even death. So malnourished patients are at a high risk for refeeding, and electrolytes should be checked often in these patients who we believe or identify as risk for refeeding syndrome. And the low levels should promptly be replaced as needed. There is no need to withhold nutrition support until the electrolytes are normal. Just close monitoring of these patients is an absolute must. So the RD's role is to perform the nutrition care process on all patients identified at nutritional risk. We are firm believers in the nutrition-focused physical exam, and they are very helpful in identifying malnutrition and should be done on all patients as appropriate. The RD must, of course, develop an individualized nutrition intervention aimed at helping the patient meet nutritional adequacy. And I think it's really important to note that if conservative or non-invasive methods are not successful, then the RD must advocate for nutrition support to prevent further deterioration of the patient's critical condition. RDs must also continually monitor the progress of malnourished patient to ensure that therapies are still appropriate. We want to always keep reassessing and reassessing. Multidisciplinary considerations, of course, the doctor, the physician, general medicine, they're the important guys. They're the chief providers of medical care. At our facility, the MDs trust us in nutrition support, but we are responsible for writing the orders and they sign them. If they don't sign the orders don't actually get fulfilled. So we're always in connection with the doctor. RNs are also extremely important players of the team. They're responsible for direct patient care 24/7. They are our go-to when we arrive on the floor to see if the patient is appropriate for visiting or maybe things that happened overnight and so on and so forth. We love our nurses. SLP, were very important in this case because they performed the modified barium swallow study and the fees to determine whether or not the patient had any swallowing difficulties requiring a texture and or liquid modification. And then case management, of course, they're always important. They determine once the patient leaves this acute setting, where are they going? Do they have the care they need? Are their needs going to be met so they don't come back here? And in this case, they helped place the patient into a long-term care facility. So to get on to our patient, this is Mr. C. He is a 78-year-old male who was admitted from home with a chief complaint of weakness. He has a 3-week history of diarrhea and poor PO intake. So past medical history, a little bit about him is he's got diabetes, heart kind of things going on with hyperlipidemia and hypertension. He does have Parkinson's disease, and he has a history of seizures that was kind of pertinent in this case. His social history is he is married. I met his wife multiple times. She was a very nice lady. He's got 3 children. He has 12 years of education. He is retired. And he did smoke for 1 year of his life, which we have to give him props for that. Not a long time, but he has since quit. Good on him. So prior to admission, he had quite a bit of medications. And I'm not going to go through all of them, but these are the ones that are pertinent to nutrition. He also had some eye drops that I chose to leave out of here because really that wasn't really related to this nutritional case. But you can see he's taking things for his dementia, things for his Parkinson's, and he's taking a lot of over-the-counter herbal treatments. And we never really understood why he was taking all of these, but here you can see all the different prior to admission medications. So he was admitted on October 2nd, and he was admitted for dehydration. Now, he actually, when he first came in, he was observation status. He was given IV fluids and now I can't say this word, ceftriaxone, and then stool studies were ordered, and he was placed on subcutaneous heparin for DVT prophylaxis. His vital signs, he did not have a temperature, his heart rate was normal, his respirations were normal. Blood pressure, pretty much normal, 135/77, a little elevated, but he does have a history of hypertension, and he was 99% on room air. He was 148 pounds at admit, 5 foot 10 inches, and with a BMI of 21.4. For his age, it's a little concerning that his BMI is kind of low, so he was already on our radar from the beginning. This is the MD's physical exam that you're looking at, which is very different from the RD's assessment that you'll soon see. But overall, there was no abnormal findings from this physical exam. The biochemical data, it's quite interesting. There are low electrolytes, and those are related to the excessive losses from his diarrhea that he had been experiencing for 3 weeks. This just confirms that he's dehydrated. He's lost a lot of his vital electrolytes. He has a high BUN, which is associated with the diagnosis of dehydration, and he has a high anion gap, which is indicative of metabolic acidosis. We can see his A1C here, which shows it's 6.8. It's a little higher than what we want diabetics to keep their range, but it's good. So his diabetes is pretty well managed. So medical treatments that Mr. C received. For dehydration, he was given magnesium sulfate 2 grams and 50 milliliters of SW. He had sodium chloride bolus and also an infusion. He was found to have a urinary tract infection from just a routine urinalysis confirmed upon admission, and he was given Rocephin, which is an antibiotic for that. For DVT prophylaxis, he was given heparin injection. Stool studies was MRSA, C. diff, and BioFire. He was given a brain CT without contrast for altered mental status, which they didn't find any abnormality there. He did have an abdominal CT, but it was failed due to abdominal pain. He had an upper GI fluoroscopy without cub, and it was a limited study. No acute esophageal, gastric, or duodenal anomaly detected. No evidence of gastric outlet obstruction, just a small hiatal hernia. Chest X-ray, no active disease seen in the chest. So our initial assessment occurred 1 day after his admission on 10/03, and we were referred from that MST, that malnutrition screening tool, for weight loss due to nausea, vomiting, and diarrhea. At this time, the patient was on a clear liquid diet, and there was only 1 meal documented in the electronic medical record. The initial assessment was more about getting to know the patient, what's the history, what's going on. So the patient's wife stated that the patient had been suffering from nausea, vomiting, and diarrhea for the last 3 weeks. At home, the patient tried to consume food but had no appetite and would gag when attempting PO intake. We found out that his normal body weight was 165, and that he has lost weight since then. If we do recall, he was 148 at admission. She really couldn't give us a time period, which is always very important to determine clinical significance. But for this case, we can just assume that it was clinically significant. We looked again at his labs, which were pretty much unchanged from admission, and he was on Rocephin, which, for the UTI, and he was getting sodium chloride just for that hydration. Our exam of the gastrointestinal tract, he complained of nausea and diarrhea, but he denied difficulty chewing, swallowing, or constipation. We were not able to actually look at his abdomen at this time. He was very, very uncomfortable. We didn't want to bother him, and we knew we would be back in. His skin, he had dry bruising and redness per the RN documentation, and he was being seen by wound care for a stage 2 pressure injury on his buttocks. At this time, he had no edema. His extremities were all fine. No abnormality there. I was able to perform a malnutrition physical exam on his arms and his face and his knees. And what I found was that he was severely protein calorie malnourished. And so that kind of staged our care plan there. He came in at 148 pounds, and with his ideal body weight being 73 kilograms, he was 93% of his ideal body weight. His usual body weight was 165, so we determined that he's 60% or 90% of his usual body weight. We did calculate his calories, and we've got a range of 1,695 to 2,034 kcals per day, 81 to 102 grams of protein per day, a little elevated due to his wound, and we determined his fluid to be the same range as his calories. All right, so nutrition diagnosis. We first diagnosed him with inadequate energy intake related to compromised GI tract and illness-induced appetite loss, as evidenced by nausea, vomiting, diarrhea, and patient's wife's report of limited PO intake for the past 3 weeks. We also found that unintended weight loss related to illness-induced appetite loss, as evidenced by a patient is 90% of usual body weight, was also applicable. For our intervention at this time, we decided to progress his diet to cardiac/consistent carbohydrate as medically able. As you remember, he was on a clear liquid diet when we saw him. And we thought we would continue with that, diet, but just to progress as needed. We did think that he could go with a supplement to help increase intake. So we're kind of thinking a little bit ahead. We don't think that he's going to stay on this clear liquid diet for very long. They're just running tests right now. So once he's able to progress, he could have a boost glucose control 2 times a day. We also marked here that he was a high risk for refeeding and that to replete of electrolytes as needed, and we encouraged by mouth intake. And because of the patient's status when we went to go visit him, we thought that providing assistance during meal times would be necessary for adequate oral intake. So our goal at this time was to increase his oral intake to 50 to 75% of meals and supplements within 3 to 5 days. And we wanted to monitor just, the diet, what he was consuming, his electrolytes, glucose, skin integrity, and comparative standards, all the same things that we typically look at in all patients. So the clinical course continues from there. We saw him on the 3rd, and on the 5th, he became unresponsive and a code blue was called. He was then, for the first time, transferred to ICU for close monitoring. On the 6th, they found that he was C. diff positive, and the patient was started on by-mouth vancomycin, which is an antibiotic. On the 6th, we also got to revisit him, and at this time, his diet had been progressed to a mechanical soft/cardiac, and he was getting the supplement that we had put in our intervention prior. What we found was that his PO intake was about 25% of meals on the current diet. However, when I went to go visit him in the ICU, the wife and the daughter were there, and they said that he ate 100% of his breakfast that morning. And that was like music to my ears. I thought, wow, we're getting on the right track. This is great. But it's also important because as it's difficult to estimate his exact intake, we're assuming he's still meeting less than 50% of his needs. So our nutrition diagnosis that we originally thought of still exists, but we're showing improvement. We're positive. So again, we went to go visit him on the 10th, and at this time, his intake was now starting to trend downwards. So our excited moment of 100% is gone. He's eating 20% of the meals provided since last assessment. I got to speak with him a little bit, and he told me that he has no appetite and no desire to eat. From his current intake, he's meeting 22% of his daily calorie needs and 22% of his daily protein needs through all meals provided. His nutrition diagnosis still exists, and there is no improvement shown between last assessment. On the 12th, we got to reassess the patient, and his intake continued to go downward. So the average PO intake was 10% of meals provided since last assessment. This is when we got serious with the patient. I had Katrina come in with me, and we're concerned. we talked to him and said that if the patient were continue to not be able to consume adequate nutrition by mouth, we were going to need to place a feeding tube. And he wanted to go to rehab after this to get strong and progress. And if he was going to go to rehab, he needed to maintain adequate energy levels for participation. At this time, the patient looked us in the eye and said he did not want a feeding tube, that his father had a feeding tube and he did not want one. So also, right after this conversation, the patient ended up having a seizure, which we got to witness, and it's pretty terrifying if you don't really know what's happening. So we were able to get the RN to come in, who was able to guide us through, leave the patient be, don't touch him, and, whatnot. And the patient was fine after the seizure, but it was very, very interesting to see that in person. So at this time, the nutrition diagnosis still existed, but there was little to no improvement shown. At this point, we decided to update the intervention. So we portrayed to the doctor that the feeding tube was not desired by the patient, but we figured that he needed to go in and talk with him. So if the patient did not want a feeding tube after talking to the doctor, we thought that he would liberalize the diet because, you know what, at this point, a therapeutic diet does not make any sense. We just need him to eat whatever. So we were going to change it to mechanical soft regular. We were going to continue with the supplement, and we were going to continue eating for comfort measures. However, if the patient wished to get the tube after talking to the doctor, we thought that full-strength diabetes source AC continuous at 65 milliliters per hour via a PEG would be appropriate. And that would be 1872 calories, which would meet 100% of needs, 94 grams of protein, which also is 100% of needs. On the 13th, we revisited the patient. His PO intake continued to trend downwards, and the last note by the doctor said that he was going to get a PEG tube. And so that was quite interesting to us, that he was now going to get one after he was so adamant about us not placing one. So the nutrition diagnosis still exists, and little to no improvement was shown. On the 16th, we reassessed again. PO intake actually had improved at this time, but it was remaining to be inadequate for his needs. He was meeting 36% of his calorie and 34% of his protein needs. And he was not able to maintain hydration. He still needed the IV fluid to be hydrated. So nutrition diagnosis was still existing. Really no improvement was shown. We did get a new weight. He was now 146 pounds, so he had lost 2 pounds since the 2nd. On the 18th, the patient was transferred to the ICU again for becoming unresponsive to stimuli and had labored breathing. On the 18th, he was placed on BiPAP in the ICU, and the MD noted that the PEG tube is agreeable per family and that they were going to continue aggressive care, but they changed his code status from full code to no code. The patient was going to be attempted to be weaned off BiPAP and then proceeded with a PEG placement if he was medically stable. On the 18th, he was 156 pounds, and that was likely related to fluid because at this time he did start becoming edematous. On the 19th, we visited the patient, and he still hadn't gotten his PEG tube. SLP had visited him but couldn't perform an assessment due to his mental alertness. He was still having poor intake. So the nutrition diagnosis still exists. There was no improvement shown. And at this point, we updated the intervention. We stated that if he does not get a PEG soon, we've got to place an NG tube to begin his tube feeding. So the same tube feeding orders were in our intervention, just now a different route. On 10/20, the PEG tube was placed. And on 10/21, he was 161 pounds. On the 22nd, we saw that the enteral nutrition was running at half of goal rate, and he was tolerating it well. And we were concerned about refeeding. So as you can see here, his potassium is low, and his magnesium is not low, but it's on the lower end of normal. So we continue to watch him very closely. On the 23rd, he did a SLP swallowing evaluation, and they found that due to generalized weakness and concern for silent aspiration, that he continued to be NPO with PEG tube feedings until he was able to get a FEES done. But he was able to tolerate all liquids during this assessment. On the 24th, the EN was running a half rate, and it never reached goal rate for a reason unknown. The SLP evaluated the patient and was concerned that the rate might be too high, as the patient had consistently complained of nausea and that it may inhibit his appetite. So this was an education opportunity for us, because we explained that the tube feeding had not reached goal until today and that it should not have an effect on that, on his nausea or any of that. And the patient is malnourished, so he needed a PEG tube. It was indicated, and that it should be used until he can take more than just a few bites to eat. So our nutrition diagnosis still exists, but he's getting energy more than what he was. That phase was completed on the 24th, and I was able to participate in them performing it. Very, very interesting procedure. I recommend that if anyone has the opportunity in their clinical rotation to watch the fees be done, to go ahead and do that. From that, the SLP recommend regular foods with thin liquids, small frequent meals. And so our final reassessment occurred on the 26th, and the diet was NPO because he was still on tube feeding, but the tube feeding was now reached at goal rate. He was tolerating it well, and I asked about his PO intake since I had watched the SLP say that he could eat from the fees study findings. The family was hesitant about starting it because the pulmonologist stated that he did not want the patient to eat due to fear of worsening and reoccurrent aspiration. Well, he didn't want the patient to relapse. So despite SLP approving the patient, nutrition clearing the patient, and the hospitalist saying the patient could eat, the pulmonologist did not. It was a kind of a big ordeal, and it was a lot of time spent in the room listening to the family's concerns and confusions about the treatment and the communication. So my job then was just to assure the patient that the family that the patient was receiving adequate nutrition from Enteral Nutrition at this time, and that I was continuing to monitor that. I then reported back to Katrina, told her all that, and the nurse was also aware of what was going on. So it was being handled. It was just an interesting situation to walk into and have no answers for. The labs, his sodium was low, his glucose was high, his BUN was high, and his calcium was low. He now has quite significant edema, +2 bilateral in the upper extremities and +1 in the lower. And he was weighing 168 pounds. And he now is over 100% of his ideal body weight and his usual body weight. But again, a lot of this was likely due to fluid accumulation. His calories remain the same. His needs were never changed. And so our new nutrition diagnosis was inadequate oral intake related to altered mental status, as evidenced by NPO and feeding tube for EN. We wanted him to be able to advance to a regular diet as medically able, since the SLP had cleared him and that his swallowing function was fine. We wanted to continue the current enteral nutrition order, but we wanted to increase the water flushes because of his high sodium. And then we wanted him to be DC'd from IVs so that he would be prepared to discharge. And our goal was that enteral nutrition would be tolerated, meaning greater than 85% of nutritional needs prior to discharge. And the monitoring evaluation is pretty much the same. So he was discharged a day later, and it was quite an interesting and long-winded case. His length of stay was 25 days. And so personal comments, I'll start from the beginning of the bullet point. So the patient should have received an NG2 for enteral feedings when placed on BiPAP. According to Katrina, in clinical settings, the pulmonologist often does not want to risk aspiration with the BiPAP because BiPAP forces inhalation and expiration with the movement of the diaphragm near the stomach. And so they choose not to place an NG tube, and the patient might not be stable enough to place an NJ tube. But what happens is the patient ends up in a caloric deficit, and it hinders their chance of weaning from BiPAP, and they become at even higher risk for malnutrition. So something should have been done, especially in a patient who is marked severely malnourished on the second. RD should not be afraid to initiate difficult conversations that are necessary for the best outcomes of the patient. So having the conversation of placing a feeding tube can be difficult to have with a patient and or family. I was a bit uncomfortable about initiating that conversation, so Katrina helped me with that. And she thinks that the most successful way to complete this task is to have the doctor and the RD talk to the patient together. Everyone ends up on the same page that way. And the patient can get the doctor's thoughts and perspectives, and the RD can explain the indications. Patient wishes versus family wishes were kind of interesting in this case. The patient, in a right state of mind, told us he did not want a peg tube, yet the family decided that he should receive one. And that's just the way that this world can sometimes be. The care gets a little blurred in between of ethics and what the patient wants versus what the family wants. Of course, the patient needed it. Elsewise, I don't know the course that this route would have taken if he did not get a peg tube, but I would assume he would have been here for even longer. And then interdisciplinary communication is key. It's important to note that the communication is effective and everyone as part of the care team is on the same page. The feeding tube, really, it was a disaster. The SLP thought that the peg was placed for swallowing deficit, but it was placed because the patient had not been eating. His swallowing was fine. I think they wanted to reassess after his seizure and all his BiPAP experience and all that stuff, but it wasn't really needed. And the SLP thought that we needed to decrease the rate, and the pump, oh God, so it was a mess. So it just, the care could have been communicated a little bit better. From a family's perspective, I probably would have been kind of confused. The family was a little bit difficult in this care process. They were demanding to be transferred. They were demanding all sorts of things, and they weren't really listening when the health professionals were coming in to talk with them. However, I can't blame them. This care was a kind of confusing, and it probably shouldn't have been. The length of stay, 25 days, is a really long time. I don't think that we probably attended to the patient's care as quickly as possible. But then again, we had hopeful signs in the beginning that PO intake was going to return. If you remember the ICU 100%, that was a glimmer of hope, and sadly that didn't come into fruition any more than that one moment. So very interesting case. I was a part of it every step of the way. I saw him from admission to discharge, and I learned quite a lot from it. There's my bibliography, and I hope you all enjoyed.